In this lecture, we'll discuss drugs that are commonly used to manage respiratory system disorders. This is a list of the drugs that we'll cover. We'll cover SABA, LABA, inhaled corticosteroids, leukotriene receptor antagonists, mainly montelukast, SAMA, LAMA, roflumilast, methylxanthines, antihistamines, intranasal corticosteroids, and decongestants. Now, in the book, you will also find one page that talks about immune therapy for asthma. Basically, we'll talk about the interleukin 5 inhibitors. This is something that you can read. I don't think you will get really lots of questions about this topic, and any questions about this topic most likely will be pre-test because these are pretty new medications. I probably will look at the storage. I would look at the frequency of use, but I wouldn't necessarily spend too much time memorizing or trying to grasp all the information about interleukin 5 inhibitors. The first class of medications we'll look at is the beta 2 agonist. And as you know, beta 2 agonists have two different classes: short acting beta 2 agonist, or the SABA, and the long acting beta 2 agonists, or the LABA. And here I try to always put the drugs that we have in Canada first. So for the short acting beta 2 agonist, we have salbutamol and terbutaline. And we have some adverse reactions for all the beta 2 agonists, short acting and long acting. So these adverse reactions are not only for the SABA, they are for the SABA and they are for the LABA. Common side effects are throat irritation, cough, and upper respiratory tract infection. But what's important that you will need to know is you need to know which side effects are beta 2 mediated and which side effects are beta 1 mediated. This is important. So beta 2 mediated side effects include vasodilation. This will be symptoms such as flushing, hypotension, reflex tachycardia, palpitation, arrhythmia, chest discomfort, angina, QTC prolongation. This is because of the vasodilation. Beta 2 mediated adverse reactions also include skeletal muscle stimulation. This leads to spasms and tremors, especially in the hands. And the tremors will disappear with continued therapy. And typically, the tremors are like having tremors. This is one of the side effects due to which the patient may stop using the beta 2 agonist because of the tremors. There is increase in the blood glucose level. Please remember, which again, very important to keep in mind, which symptoms are beta 2 agonist, beta 2 effect, and which symptoms are beta 1 effect. So increasing the blood glucose level, this is beta 2 mediated effect, and increase in the insulin secretion. Don't look at these two and say, oh, how come there is increase in the blood glucose level and increase in the insulin secretion? Both of them can happen. Maybe there is, at the end, they will balance each other, but both of them are beta 2 mediated effect. Patients may develop hypokalemia, cause fatigue and muscle weakness, unusual taste, and dryness or irritation of the oropharynx. This is due to the thickening of the saliva, decreased GI motility, causing nausea and vomiting, and CNS stimulation, causing insomnia, nervousness and anxiety, irritability, restlessness, and hyperactivity. These are all beta 2 mediated adverse reactions. Beta 1 mediated adverse reactions are unlikely because of the selectivity, but this can cause hypertension, angina, chest discomfort, palpitation, and arrhythmia. And this is because of the stimulation of the beta 1 receptors in the heart. But this is unlikely considering that we use these medications. Number one, they are selective. Number two, we use them as inhalers. So the chance of systemic effect is small. Other adverse reactions include drowsiness, vertigo, dizziness, dyspnea. Dyspnea is paradoxical. Paradoxical means it's unexplained. We don't know exactly what causes dyspnea, and in this case, we will discontinue therapy. Sometimes we will give the drug to treat a condition, and all of a sudden the condition gets worse. If this happens, we typically discontinue the drug because this is a paradoxical side effect. Urine retention, this is beta 3 mediated. Headache, weakness, dizziness, upper respiratory tract infection, hallucination, or atypical psychosis, rare hyperactivity in children, and rare hypersensitivity reactions. These adverse reactions apply to SABA and apply to LABA. Some notes here. Inadequate response to SABA makes asthma diagnosis questionable. We said that before. If we give the patient salbutamol and the asthma does not improve, this makes us question whether this is really asthma or not. Patients who cannot tolerate the tremors and the tachycardia due to SABA can be switched to ipratropium. Ipratropium plus SABA will increase the risk of tachycardia. So if the patient uses salbutamol and the patient cannot tolerate the tremors and the palpitation, we can switch the patient to ipratropium. But combining ipratropium and SABA will increase tachycardia because they work on two different nervous systems, sympathetic and parasympathetic. So if we use both, the patient will have even more tachycardia. Oral beta 2 agonists, such as orsiprenylin and salbutamol, they have a slower onset of action, less bronchodilation, and more adverse reactions. In my 16, 17 years of practice now, I cannot recall at all dispensing oral salbutamol, for example. Non-selective beta-2 agonists, such as isoproterenol and epinephrine, they cause more cardiac side effects. And the main indication of isoproterenol is as a cardiac stimulant in patients with cardiac shock as injection. It's used as injection to stimulate the heart in patients with cardiac shock. For the long-acting beta-2 agonist, we have different drugs here. We have salmeterol available as Serevent, and we have formoterol available as oxys. And of course, they are also available in combination with steroids. So salmeterol with the fluticasone is the Advair, formoterol with the Symbicort is, formoterol with budesonide is Symbicort. Don't worry about the names. The names are coming, and you don't have to know the brand names anyway. Indacatrol, Indacatrol and Oladetrol, these are used in COPD. Vilantrol is used in COPD and is used in asthma. So from the LABA, there are three that are used in asthma: formoterol, salmeterol, and Vilantrol. Few points about LABA. LABA can be used for exercise-induced asthma. Adding LABA to inhaled corticosteroid reduce exacerbation and allow the use of lower dose of inhaled corticosteroids. So that's why, if you still remember, in step 3 of the steps of managing asthma, we combine inhaled corticosteroid with LABA, and we said that we may not use LABA and use leukotriene receptor antagonist, but leukotriene receptor antagonist is less effective than LABA. Adding LABA to inhaled corticosteroid reduces exacerbation and allow using a lower dose of inhaled corticosteroid. Formoterol can be used as rescue therapy in patients on inhaled corticosteroid. So the Symbicort, the brand name, formoterol plus budesonide, and the dose is 1 inhalation PRN. Of course, according to the new guidelines that we spent significant time discussing, this is becoming the reliever of the first choice, the use of inhaled corticosteroid plus formoterol. The second class of medications that we'll look at is inhaled corticosteroids. So the drugs we have in Canada, we have fluticasone propionate, we have fluticasone furoate, we have mometazone, we have budesonide, beclomethasone, cyclizonide, and they are available in combination with LABA. All of them are available in combination with LABA except beclomethasone. Beclomethasone is available only as beclomethasone, doesn't come in combination with LABA. Indications of inhaled corticosteroids, they are used as prophylactic management in asthma alone or in combination with LABA. Prophylactic here doesn't mean to prevent asthma, it means to prevent asthma exacerbation and inflammation. So they are used as a controller. The combination of budesonide and formoterol is indicated for maintenance and rescue therapy of asthma, not COPD, in patients 12 years and older with a maximum daily dose of 8 inhalations. So that's the maximum daily dose. Fluticasone and budesonide are used in combination with LABA in patients with COPD. And if you still remember, in the COPD, we mentioned that inhaled corticosteroids are not as critical in COPD. In COPD, our main goal is bronchodilation. We start with PRN, with SABA and SAMA, short-acting beta agonist and muscarinic antagonist, and then we add the long-acting muscarinic antagonist like tiotropium, and then we add LABA, and then later we will add inhaled corticosteroids. So here they are talking about candidates for using inhaled corticosteroids in COPD. So these are patients with one or more exacerbation per year that require systemic steroid. According to the CPH A monograph, more than 2 exacerbation. So that the one or more exacerbation according to the CPHA monograph. CTC says more than 2 exacerbation. I don't think this is something you have to worry too much about. You just need to know the stepwise approach for the management of the COPD.